Right. Good evening, everybody. Thank you, Dr. Manish, for the very kind introduction, and thank you for having me here today. So for the next 15-20 minutes, I'm going to try and illustrate the importance of, NGS and molecular profiling, particularly in lung cancer. So let's get started. Now, we know the field of oncology, it has evolved. We've gone from an era where it was all about understanding what permutation combination of chemotherapy should we use, and irrespective of whatever we did, and there were seminal studies in the British Journal of Medicine and Nature publication, the overall median was, overall survival was abysmal around 7.9 to 8 months. And it was around the same time that, journals started reporting the first draft of the Human Genome Project. And it's now that we began to understand the human genome, could we actually come to appreciate the cancer genome? And as we studied lung cancer, we began to understand the various oncogenic driver mutations, their genetic aberrations, combined with the data from the Human Genome Project, which actually helped us chalk out potential targeted therapies. Now, the tyrosine kinase inhibitor pathway we know has revolutionized the way that we treat our patients with lung cancers. EGFR, ALK, ROS1. We know our patients, when they get molecularly matched with a TKI, they respond far better than our chemotherapy. And in order to support this today, we have a variety of platforms and technologies like FISH, IHC, PCR, and NGS. Now we know that NGS is fast becoming the popular platform of choice, and to help call out these biomarkers, and it's making us, it's helping us with, guiding treatment options, which in turn actually is, where it's actually improving the median overall survival of our patients. So what have we learned about lung cancer? We've learned that's possibly one of the most molecularly diverse cancers. If you just look at the NSCLC cohort in particular, just see how it's evolved. You've gone from treating NSCLC as one large homogeneous group to slowly, we moved on to categorizing it based on its histological subtypes. And if you just look at the adenocarcinoma subtype, it's really molecularly diverse. And I wouldn't draw your attention to this greater than one mutation, 3%, one oncogenic driver mutation. This actually constitutes for 3% of our cases. And I want you to keep this little one in mind, because I'm going to revisit it in a bit. So what does our landscape look like for us? So here is a screenshot of the most recent NCCN guidelines. Gone are the days when it was just about EGFR, ALK, ROS1. You've got a plethora of biomarkers that is highly recommended, and not just for the adenocarcinoma, even for the squamous cell carcinoma. So upfront, it is recommended. So we are very familiar with these biomarkers. We've heard about them time and again. So I'm not really going to spend too much time talking about them, but I want to bring your attention to this very beautiful pie chart that very nicely highlights all the somatic aberrations, that we see in the adenotype of NSCLC. And while KRAS is very common, particularly in our smoking cohort, there's a wide variety of somatic aberrations. And if you see, I use the word aberrations, right? That's because some of them could be fusions, some of them could be point mutations. So there's a variety of structural variants, and hence my word somatic aberrations. And majority of these are easily druggable by a variety of drugs. And what this actually does is it actually allows us to classify our tumors into what I like to call the beginner's guide to targeted drug therapy. So you've got those tumors that are oncogenic addicted. All you need to know is what is the particular driver mutation, you molecularly match it to the drug. But then you have those where it really doesn't matter, what the mutation is. That tumor is addicted to immunotherapy. And when you get it right, it really works wonderfully. So this was a 59-year-old female, EGFR positive. She was put on Jaftamine. The patient showed remarkable response and reported to have, overall quality of life was far more better. Now, one very important thing about these molecular targets is that they're highly effective, but they're not always curative. Now, let's very quickly review, our sample options, that we have for molecular testing. Now, we know tissue biopsy has always been the gold standard. There's no argument there, right? You do a biopsy at diagnosis, at progression, you do a biopsy, preferably from a new metastatic site. However, the ground reality is that while we like our blocks looking like this, tissue does become an issue. And to combat tissue being an issue, liquid biopsy is a very, very good alternative. So in stage 3B and above lung cancer, you can actually isolate the ctDNA, the circulating tumor DNA, from the bloodstream. So your ctDNA is the somatic DNA that is released from the cancer cells into the bloodstream, and the ctDNA is isolated, and on that the molecular tumor profiling is done. So one of the key apprehensions, the concerns that we've always had around liquid biopsy was its concordance with tissue biopsy. And the Nile slip pen studies, where they've actually used clinical samples of patients with NSCLC. They've used as biomarkers, the 7-8 biomarkers that are recommended by NCCN, and they saw a concordance between tissue and liquid of around 98%. In addition, liquid biopsy did have a couple of pros where it kind of slightly trumped over tissue biopsy. Now, because it's non-invasive, you can actually, one, monitor the treatment response, two, monitor resistance mutations, and three, it addresses the issue of tumor heterogeneity. And this is something similar, that was being addressed in the IASLC consensus statement that was led by Dr. Christian Rolfo. And we were reminded that, there are some key differences between the two. So with tissue biopsy, of course, you get the cancer diagnosis, the pathology information, and an assessment of markers like PD-L1 that is, non-genomic. However, there's a lot of good data and work coming out where they're using circulating tumor cells, using the concept of flow cytometry for actually calling out these PD-L1 mutations on liquid biopsies. And exciting work happening there. But we know that, of course, all of this, it's challenging to repeat biopsies, and and biopsies are also not are not reflective, of tumor heterogeneity. So liquid biopsy is found to be highly concordant. It's fast. We know it's minimally invasive, and it's very easy to repeat over time, and perhaps better to capture tumor heterogeneity. But this consensus did say that, it doesn't have the exact 100% sensitivity of tissue, but it's not inferior either. So this is what they are recommending, in the clinic in treatment-naive patients that that there are three approaches that they're recommending for liquid biopsy. The first one is a sequential approach where the tissue testing has failed, so you send it in for a liquid biopsy. The second is a complementary approach. And honestly, when cost is not an issue, I think this is a fantastic approach where you do both upfront, tissue and liquid. The third is the plasma first approach, where when you're very sure that there's not going to be any sufficient tissue, surgery, biopsy is not an option, and tissue is not accessible, then you do liquid biopsy upfront. Now, for these biomarkers, there are many validated platform technologies that are available to call out the variants, but NGS is my preferred platform. Now, I'm not going to be belittling the standard of care of platforms like, your RT-PCR, your FISH, IHC, because I feel with NGS, we get the answer to the tumor biology. I think today when we treat cancer, it's not just about these biomarkers, it's the biology of the tumor. While some of the genes, some of those oncogenic driver mutations may not have a targeted therapy, but they actually have prognostic value, or it helps you understand the biology. Is this TP53? We know the presence of a TP53 is going to prevent or not allow my patient to have the ideal response to a TKI. It inhibits an EGFR mutation. So information like this is something that NGS can give you in one shot, in one sitting, versus your standard of care platform. In addition, what's happening is that NGS is also proven to be cost effective. The cost has come down. You've got an improved TAT, at least a basic lung panel, which the 12 odd genes of importance. You get a result in 15 days. Tissue preservation, irrespective of using Thermo Fisher or Illumina, you need some good quality 20 nanograms to maybe 100 nanogram DNA. But the key point for me is that where I truly feel that, especially in lung, which is such a molecularly diverse cancer, where NGS trumps the standard of care, is it has, one, the potential to discover more actionable targets. So you're going beyond the EGFR exon 18, 19, 21, or even within those exons, you have the capability of calling out those rare novel mutations. And the pie chart that I'd shown you earlier, where I said there was a possibility of having more than one oncogenic driver mutation, which is 3%. 3% we think is, it's a really small number, but in sheer volume for a patient care, that 3% actually helps, call out and helps you as oncologists design as to what would be the best treatment option for your patient. And all this gets done in one go. So you're actually helping guide and chart out a more personalized treatment for our patients. And why here, this is a very simple data set that is from my personal clinic. And while we have 38.9% actionable targets, alterations, what was very important are the concomitant genomic alterations that we're seeing over here. EGFR, we know different types of EGFR mutations respond better to a different type of target. EGFR with TP53, EGFR with KRAS, EGFR with ALK. All these mutations simultaneously actually help us make very informed decisions as to how we're going to look after our patients. Now, this is an incomplete data set, but just, something within those 10, 12 genes of importance, what we've identified. Now, moving on to, I can give you our data, but let me just use two biomarkers that we're very comfortable with in our practice. So to further illustrate as to why I think NGS is a really, really important platform in lung cancer. So in an unselected population, you identify, let's say, an EGFR mutation, you put your patient on a TKI, you know that after a period of time, it does develop resistance, and we use imaging to confirm it. Now we do a rebiopsy, and preferably from the new metastatic site, or if rebiopsy is not an option, we do a liquid biopsy. Irrespective of sample type, we send the sample for molecular profiling. Now we've identified that the most common resistance mutation to EGFR is the T790M, and it accounts for around 60% of these cases. But in addition to this, we also have a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, your HER2, and more importantly enough, your small cell transformations. Similarly, when a patient progresses on osimertinib, it acquires resistance mutations. And again, we saw this in the AURA3 trials that that around 15% of these patients get a C797X mutation, and that's about 19%. So then you've got those that are positive for a MET amplification, HER2 amplification, which is around 5%. And all of these mutations can be reported in one go using NGS as your platform of choice. And similarly with ALK, it's no more about being ALK positive, it's about which is the fusion partner that is with ALK. Is it a point mutation? And accordingly, if a patient's progressed on, let's say, crizotinib, which type of mutation? Now, crizotinib G1202R is a very common mutation. We know if my patient has that, I'm not going to, I'd have to change therapy, maybe for the patient's serotinib or lectinib, or on which it would possibly respond better. And all this can be done using next generation sequencing. And for me, this is where we are in 2022. Look at the plethora. There's a plethora of biomarkers, and we can see there are a couple of new additions. So we're very quickly going to talk about them. I've got my NTRK fusions. We know they're rare. They constitute for around 0.2% of our NSCLC cases. These are agnostic markers. And we see from these waterfall plots that entrectinib, larotrectinib, that across the board, across all solid tumors, lung cancer included, our patients do respond really well. Then what essentially are we looking for? So in NTRK is essentially the rearrangement of the genes. It's a fusion partner, and the most common fusions that we see in NSCLCs, NTRK1 is with TP53, CD74, TPM3, three very common fusion partners, and in NTRK3 we see the ETV6 and the EML4. So how do we test this? Being a fusion partner, ideally, I know ESMO talks about ESMO talks about using FISH and IHC, but in my very humble opinion, I think it's just better that we stick to NGS because it's got a far more higher sensitivity, and RNA NGS, because we know anytime you're looking for a fusion, be it ALK, ROS, MET, any fusion across the board, RNA NGS is your platform of choice. If your service provider gives you a report and it's negative, I think it's important that you go back, check with your service provider and say, my NGS report is negative for an NTRK mutation. Is it a true negative? Have you done DNA or RNA NGS? If they say they've done DNA NGS, I very strongly recommend doing an RNA NGS. Now we talk about RET. RET is, we know, synonymous with papillary thyroid carcinomas, but it actually constitutes for 1 to 2% of NSCLC cases. Again, RET gene is a rearrangement, it is a fusion, and the most common fusion partner we see in our NSCLC cohort is the KIF5B, and this is followed by the CCD6. I'm talking about NSCLC in particular. Again, it's a fusion. So for me, I think NGS is my preferred platform of choice. My therapy options are selpercatinib, which is what we get from the Libretto 001 trials, and pralsetinib, which is from the Arrow trials. Now we move on to the MET exon 14 skipping. Now it's a mutation that occurs at the junction of exon 13 and exon 14, and this leads to the skipping of exon 14. And the product is a fusion partner of exon 13 and exon 15. Again, a fusion, so it has to be RNA NGS. And your therapies of choice is crizotinib from the Profile 101 trials. You've got capmatinib from the Geometry trials, and you've got tepotinib, I think, from the Vision trials. Now we move on to KRAS, right? This is one of the latest additions to the biomarkers circuit. Now it's one of the most common cancers in NSCLC. They constitute for around 25 to 33% of cases, especially in our smoking cohort. So what you're doing is you're essentially looking for a mutation in the GTP binding protein that connects the receptors of the tyrosine kinase. Now from this subtype, G12C is the most common. It constitutes for around 40% of these KRAS cases. And what's interesting in this particular subgroup are the varying TMB rates. So G13 has a high TMB followed by G12C, and G12D has a propensity for a lower tumor mutation burden. Even the PD-L1 rates are high, with a high TPS score is what we see in the G12C and the G12D. And we use NGS as a platform of choice. But in this case, maybe RT-PCR, if you're just looking for KRAS, can be done, but NGS is my preferred platform of choice. So sotorasib is my therapy of choice from the Amgen trials. And we talk about immunotherapy because this talk would be incomplete. Keynote 010 and Checkmate 017 Oak trials. They've demonstrated the utility of PD-L1. We've got 3 clones, 22C3, which is on DACO, SP263 on Ventana, and SP142 on Ventana. You look at the TPS score, you see if the patient is a candidate for immunotherapy. Similarly, we have something called tumor mutation burden. I personally think it's slightly controversial as an immunotherapy biomarker, especially in lung. So the key theory is that every cancer's got a mutation, and more the mutation, higher the neoantigen load, and possibly a better immune response. So in the lab, on a minimum 250 gene panel, you look at the number of genetic aberrations that are there, in the exonic region, and this gives you an indirect idea whether or not the tumor you're dealing with has a high or a low neoantigen. And this is where I think that there's a slight issue with the theory that not every mutation would really cause a tumor to have a neoantigen, and they may have neoantigens, but may not necessarily be the neoantigen that is recognized by the immune system. So the neoantigen may not really induce an immune response, and also one size fits all of a TMB score of greater than or equal to 10 mutations per megabase may not really be ideal. So I do think it's still experimental. I think there have to be different cutoffs for different solid tumors. But since the FDA has given us blanket approvals, when you've got your back up against the wall, I would say you could use it as a biomarker, but I'd say tread very carefully. And this is the beauty about NSCLC. This is forever a changing field, right? This is emerging biomarkers. So sotorasib, we already have approvals for it. But look at this, you've got HER2 exon 20 insertions. I know we've got now approvals for that. But look at the NRG1 fusions, HER3, look at their incidence rate. You're increasing the cohort of patients that could be possibly molecularly matched with with therapy. So this is the beauty about lung cancer in particular. The last 2 minutes, I'm going to very quickly take you through what I do in my clinic. So upfront, any new case that comes to us, NGS is my preferred platform of choice. There's no doubt about it. NGS with PD-L1. In the case where there's a recurrent or progression on disease at this point, I do like to do a molecular profiling. Tissue biopsy from the new metastatic site. If that's not possible, I would do a liquid biopsy. If one comes negative as a reflex, I would do the other. Sample choice, and I would go a little bit beyond the 10-12 genes because now I want to understand the tumor biology. If PD-L1 is not done, I would be doing a PD-L1 over here. Now, this was a case of a 50-year-old female NSCLC We did the very typical sequential testing where we did the EGFR by PCR, we did ALK by IHC, ROS1 by IHC, and FISH, it came negative, and she refused to go for chemotherapy. So luckily we had some, we had some tissue left with us. So we went and did NGS, and she came back positive for a BRAF, and she started on a BRAF MEK inhibitor. So 12 days we got the report versus the sequential testing, which took approximately 3 weeks. Again, another case of a 79-year-old male non-smoker, was EGFR positive. They've started an afatinib. He progressed. They did a rebiopsy. No mutation was detected. Old guy. It was in the peak of COVID. We were not very comfortable giving chemotherapy. At this point, we set it in for a liquid biopsy. We found a MET exon 14 skipping mutation, a VAF around 0.4%. And what happens over here is that when you increase the depth of coverage to around 15,000, 20,000 next, you're increasing the sensitivity and specificity to call out these small variants. And that's where liquid biopsy has a slight edge over tissue biopsy. And this actually helps us. Obviously, this is a case of tumor heterogeneity. That's why it was not even caught on tissue testing. And this patient was started on capmatinib. Now, my last case, and then I'm done for this, was an 81-year-old female with NSCLC. Tumor was insufficient. We sent her for a liquid biopsy. She came positive for a ROS1 mutation. She was put on crizotinib. She eventually progressed. She refused to do a tissue biopsy, so we again sent it in for a liquid biopsy. She had ROS1 was persistent, but she had acquired a ROS1 G2101A, which we know is a known crizotinib resistance mutation. So she was put on lorlatinib. This was short-lived. She again progressed, and liquid biopsy was repeated. Now, just watch the KRAS mutations over here. Over here, we saw the ROS1 fusion was persistent. She had lost the ROS1 2101A, but gained a ROS1 2032R. And in addition to this, she had lost the KRAS K117, and had now got the KRAS 12B, which we know binimetinib is a targeted therapy. But you've got to be careful because this could be a potential CHIP mutation. CHIP mutations can be mistaken for being old, blood cells, especially in patients that were smokers, heavily pretreated. It can be they can be mistaken for being these discarded old WBCs. And CHIP is essentially clonal hematopoiesis of indeterminate potential. So if we see TP53, KRAS, JAK2 in our NGS reports, especially in NSCLC with a VAF less than 0.1%, go back, check with your service provider to ensure that it is that it is a CHIP or a true mutation. And this is my last slide. I think this is where we are. These are 50% of your NSCLC patients are going to fall within these biomarkers, which means that if you're using NGS, you can capture all this in one shot without having to go through sequential testing. And hopefully a larger cohort of your patients get molecularly matched to targeted therapy. And on that note, thank you very much for your patient listening.
Hello. Am I audible?
Yes, you are.
Thank you so much for this nice and beautiful presentation. So the session is open for discussion. Any questions? We can take you 1 or 2 questions. Dr. Aparna, you talked highly about the liquid biopsies. So what do you say? They basically detect heterogeneity among the tumor also. So they can detect few of the mutations which may not be present in the tissue tumor. So do you recommend doing both of them at the same time? This is one of the question. And another question is, if we do NGS on a tissue testing and we don't find any mutation in that, so we take it on face value, or should we repeat doing some ALK by IHC? Because few of our patients, they have shown IHC positivity by ALK, although they were negative by NGS. And one of my patients, similar thing happened with the ROS one also. So should we take it at face value, or what should we do?
Thank you for that question, both the questions. So I'll answer the first one about doing both together as liquid and tissue. If a patient can afford, absolutely. I think it's a brilliant idea, especially in metastatic stage 3B and above. I do think it's a good idea doing both of these tests together, tissue and liquid, just so that you get a clear understanding. Sometimes what happens is that there is a resistance mutation lurking in the background, and we're not even aware of it. So you could have an EGFR patient, and you could have a MET mutation, a MET exon 14, just lurking behind at a 0.01%. So you're aware of it. You know that your patient's going to have a resistance, and you can maybe plan better and look after your patient in a more different way. So upfront, yes, but obviously everybody cannot afford it. So if you do tissue testing, and in tissue testing it comes back negative, I would then, as a reflex, do liquid test, liquid biopsy. To answer your question about the discordance between NGS and IHC, the two questions I would have. You're talking about ALK and ROS. ALK and ROS are best identified on RNA NGS because these are fusions. So while your IHC would say, yes, it's positive, we are seeing an expression, it can be that it got missed out on NGS because it was DNA NGS. You need to do RNA NGS. I find it very, I've come across one case only where IHC was positive and the NGS was negative, and that was because the DNA NGS was done and not a RNA NGS. And that could be the reason that there was a discordance between the two testing types. Now with ROS1, if it comes positive on IHC, as per the guidelines, you have to confirm it by FISH. A ROS1 cannot be taken as positive as on face value. It has to be done ROS1 on FISH. So this way or that way, I think that the key question is going back and checking with your service provider what type of NGS was done. And it can also be that, sorry?
So nowadays, whatever NGS we are doing, I think most of the service providers, and especially in Rajiv Gandhi, we are doing by both DNA and RNA.
That's correct. That's correct.
Most of the fusions, they are detected by RNA better, as you rightly said. So
Yeah.
One more question. So those patients who are having early stage NSCLC and they have been resected. So after resection, can NGS help us in determining the minimal residual disease as in myeloma, for example, or ALL, for example? So can we select few of our patients who will have benefit with the additional treatment in adjuvant setting? So can we have that?
There is data around it. There is testing around it. We do offer it, but I think you're one of the first clinicians who's actually asking me in lung cancer if they can do that. So I'm not seeing it upfront being done, but yes, the platform, the opportunity is available. So if needed, it can be done. I would recommend it, but then again, at the end of the day, as a treating clinician, it is your decision as to how you want to go forward. But I would recommend it. I don't see why not.
I think so. With the less of the tumor burden, I think it is more difficult to detect ctDNAs on.
That's right. I would do it on tissue. For this, I would do it on tissue. So with lung, I'm not comfortable doing liquid testing, ctDNA testing on anything less than stage 3B. I don't think any of us, any lab, anyone can proclaim and say what they want, but I don't think any of the labs have the sensitivity or the specificity for calling out anything less than stage 3B, because even gold standards like Guardant and Foundation will not accept a sample less than stage 3B because everybody's validated it on that. So, and all the studies for concordance in lung with tissue has been stage 3B and above. So anything less than that, I would stick to tissue testing. And if tissue is not available, then well, we obviously can't do the testing.
Thank you, Dr. Aparna, for such a wonderful session. I think if there are no further questions, we will move to next session.
Thank you so much for having me. Thank you.
So, Dr. Aparna, hi. I'm Dr. Praveen. I have one question for you.
Hi.
Yeah, hi. So my question is, those like nowadays we are doing EGFR testing in early lung cancer. We try to do it on almost all the patients. So do you think that because recently I had one patient who was operated in AIMS. So AIMS people, they do not give the block to us, but the initial biopsy was done in my hospital. So can we perform EGFR mutation testing in the primary biopsy specimen also, or and is there any data whether the primary tumor versus metastatic tumor, not metastatic, the resection specimen? So is there a difference in the EGFR incidence rates and all?
To be very honest, I've not come across any data which shows a difference in the EGFR between at biopsy and after resection. So it would be very uninformed, uneducated of me to say there is a difference. But I don't see why it should be a problem that at biopsy, at diagnosis, or on that biopsy, you perform EGFR, why there should be a difference between that and the tissue testing at resection in early lung cancer. So I think it can be done on the primary that is with you.
Okay. And many a times we come across a situation where the patient is not willing for biopsies for the diagnosis, and sometimes the patient is medically in such a condition that you are not able to perform a biopsy, be it because of emphysema and repeated bronchoscopies, they have given negative results. So, and there are companies who are promoting liquid biopsies for the diagnosis also. So I do not know. So logically, we can do it, but legally we cannot do it. This is my understanding. So what is your take on that?
I am not comfortable using liquid biopsy for diagnosis. I don't think liquid biopsy diagnosis can replace pathology. I don't think we're there at all. So I think when they, I'm not really sure who these companies are, but I would not be comfortable giving it to any of my patients or recommending it. It has to be validated. There's a lot of clinical work that goes in before we bring it into, a lot of research R&D work that goes in before we bring it into clinical practice. So I'm not comfortable till I've not seen data. And yeah.
And are there any researches going on in this aspect?
So the one that I'm very familiar with, because there are a couple, there's a lab I know in Pune that's working on using liquid biopsy as a base for calling out PD-L1 positivity. And that's what I mentioned, they use CTC, circulating tumor cells, irrespective of what stage of cancer the patient has. So that is the only area where I'm seeing some concrete work being done with CTC for PD-L1, for HER2, and I think for there's one more which I cannot remember. I think ERPR or something like that. But that's the only area that they're doing work that I'm familiar with. But anything over and above that, I'm not in India for sure.
Okay, thank you.